Is a CT ultrasound picture of a kidney showing multiple hyperechoic lesions. This is a very classical appearance of angiomyolipoma involving the kidney. And this again CT demonstrating the fat within. This is the fat values less than minus. This is showing the minus values. So this is a homogeneously enhancing lesion, but for the fat component within that. And it is not as aggressive as an renal cell carcinoma and shows homogeneous enhancement. This MRI is very useful in detecting small amounts of fat, lipid within the angiomyolipomas. So we do in-phase and out-phase images to detect a small amount of fat. This is in-phase. You can see the bright signal on in-phase image, and this is partially suppressed on a post-phase image. This is angiomyolipoma. On contrast, you can see this heterogeneous enhancement, the solid component of the angiomyolipoma. After solid masses, there are certain infiltrating masses which are diagnosed, detected, or routinely on imaging modalities. These are the infiltrating masses are renal cell carcinomas, are for sarcomatous type, and anaplastic transitional carcinomas, lymphomas, and metastasis. The lymphomas are usually can be infiltrate from the adjacent organs. They can infiltrate through the renal sinus into the kidney, or they can also surround the kidney. They can be infiltrative or it can be solitary, and usually they are bilateral. And metastatic disease is also from primary, usually from CL lung, breast, and colon. So they are also usually bilateral, and they are poorly enhancing. This is a case with of lymphoma. You can see a solitary hypodense lesion, not much enhancement. And this is bilateral renal masses. You can also see this is secondary involvement of the kidney by the lymphoma. And this is the retroperitoneal lymph nodes of a patient with known case of systemic lymphoma. Now this is the mass surrounding the kidney. This is another again a lymphoma surrounding the kidney. This is another pattern of lymphoma. This is the plain and the contrast. This is the infiltrating translucent carcinoma. You can see the extent of the lesion. Usually it will be seen as a filling defect in the pelvic acid system. And this is also extending along the ureter. You can see this almost the mid ureteric level. This is the mass is extending. This is a very classical appearance of translucent carcinoma. Now coming to the cystic neoplasms, this is very important because the Bosniak has classified cystic neoplasms into 4 categories. 1 and 2 are they have no malignant potential based on the wall, based on the septations, depending on the type of calcification and enhancement pattern. Based on this 1 and 2 Bosniak cysts, they have a 0% malignant potential, so they need not be disturbed. Type 2F is have a 5% malignant potential because they are slightly more complex than the 2. And they have multiple septae are more than 2, and they need to be followed up. And Bosniak type 3 is indeterminate lesions. They have a 54% chance of a malignant potential. So these need to be undergo a partial nephrectomy or a complete nephrectomy or a radiation frequency ablation depending on the patient's condition. Now type 4 is a clear-cut case of a malignancy, 100% malignant potential, and this need to be dealt with surgically. This is also an image showing a simple cyst, type 1, Bosniak type 1. How do we say ultrasound is clearly just showing a homogeneously anechoic lesion, so you can say it's a simple cyst. On CT, the lesions, when do you say it is a simple cyst? At least 1/3 of the cyst should be projected from the kidney and should be homogeneous and measuring less than 10 Hounsfield units, and it should not show any wall. Wall should be imperceptible. Remember this is very important. There should not be any enhancement whatsoever on contrast administration. This cyst should not show any amount of contrast enhancement. Then you can say it's a simple cyst. So this is a simple cyst type 2. You can see this is a milk calcium in the dependent area, and this is a bit of calcium there in the wall of the cyst. This is a hyperintended cyst. You can see this. You can measure the ounce veriness. This is a plain scan. This is a contrast, delayed scan. There is not much enhancement here. 68 and 70. And CT and ultrasound, the same thing taken up for ultrasound. This shows there is a septum with a calcification. Within the septum, this is a type 2 cyst. Now that is a non-surgical hyperintended cyst. Now this is a surgical hyperintended cyst mass. You can see this is almost similar to a little less than the adjacent parenchyma on plain scan, measuring 29 to 30 ounces approximately. And in the nephrographic phase, the lesion is measuring 42. There is increase in the almost more than 20 ounce units in the nephrographic phase, showing enhancement. This is very important. Now you can see this lesion is in the extremity phase measuring 35, 30, 36 ounce units. If you don't acquire this nephrographic phase, you can think that they can misinterpret this as a non-enhancing or benign mass. So this is the importance of the nephrographic phase. You should always acquire the image in the nephrographic phase at a 90-second delay. So now this is a benign septa thin, less than 2 mm, and here you can see the malignant septum, thick, irregular, nodular enhancement. This is a clear-cut case of JYOTHSNA type 4 renal cell carcinoma with clumpy calcifications and showing enhancement, heterogeneous enhancement on contrast. Differentiation of the inflammatory cystic mass from a cystic RCC. You can see this wall. You can see this is not very clear on the plane. You can see this thick enhancing wall in the posterior aspect. And this is inflammatory mass. How do you differentiate this? Enhancement of this wall of inflammatory cystic mass is less than the cortical enhancement. And you can see some edema around it. This is what is a inflammatory cystic mass. And this is a papillary RCC. And that, as I said, there is some pseudotumors and renal mass mimicus. They can be differentiated based on the CT and MRI, as they show the same similar enhancement as the rest of the renal cortex. The role of biopsy is preserved. Transaction carcinoma usually should not be biopsied because of proceeding. And any doubt of any renal mass or renal cell carcinoma should undergo a biopsy, or a lymphoma if it does not respond to treatment. A suspected lymphoma, primary lymphoma or systemic lymphoma, which is harboring a lesion and the deposits in the kidney, if it does not respond to treatment, should undergo a biopsy. That is the role of biopsy. So we have seen that how do you evaluate a mass if it is an incident detector on a routine screen and also CT or MRI. So it is important the technique is very important, and it is very important to know what are the conditions that can mimic enhancement or pseudo-enhancement, mimic a mass, and how to differentiate a enhancement from a pseudo-enhancement. These are the important features to differentiate these renal masses.